Manisha, please.
My presentation. So good morning everyone, and syphilitic uveitis is something which was initially very rare in our country, but now apparently it's on the rise, and that is why it is an entity which we all need to recognize very timely in our clinics. This was my initial experience of managing one patient who presented to my clinic, and not for being aware so much about syphilitic uveitis, but fortunately I had attended a uveitis conference, and that's where a case was presented, and probably that is something which really helped me to recognize this particular case. So she was a 38-year-old unmarried female patient who presented with pain, redness, blurring of vision in the left eye for last 5 days, and she also complained of photophobia and floaters in the left eye. She had a history of hypothyroidism, nausea and vomiting associated with stomach ache, history of recurrent ulcerations over the breasts and hair loss. However, there was no history of exposure. Now, in our cultural background, if we have an unmarried female, we are a little reluctant to ask beyond this, and that's why we were quite sure that we were not dealing with something like a sexually transmitted disease. She was already on treatment for anemia, esophageal reflux, and also for hypothyroidism. So when we examined, her right eye had a best corrected visual acuity of 6.6 N6, while the left eye, the vision was as low as hand movements close to face, with some element of anterior uveitis. So this is how the right eye appeared. Though she had a vision of 6.6, you had this typical posterior plecoid retinochoroiditis in the right eye, while in the left eye you had a hyperemic optic nerve head with these typical intraretinal precipitates. Now this is something which we really need to recognize, and a patch of retinochoroiditis in the left eye. So she was advised investigations, but was lost to follow-up for 3 weeks and was investigated elsewhere. And you see, these are the whole gamut of investigations that she underwent at some other place which were quite irrelevant. So these are the other investigations, but what was significant was that we had a Mantoux which was 0, and the rest were all very indefinitive or very irrelevant investigations. So she was diagnosed elsewhere as viral retinitis, because you see over here, all these came out to be positive, and that's where probably the other clinician felt they were dealing with a viral retinitis in this patient, and she was started on a tablet valcyclovir 1 gram TDS with oral steroids. So she presented again after 1 month to us, because now she started losing vision in the right eye for last 2 days, and she had ocular pain in both the eyes. And the initial presentation with the 6.6 vision in the right eye, she had dropped down to 6.36 N24 in the right eye as well now when she presented again to our clinic. So she had this ground glass retinochoroiditis in the right eye, and you see in the left eye the lesions had further progressed and they were appearing to be more fulminant. This is how she appeared on the autofluorescence, and when we did a fundus fluorescein angiography, what you see is this leading edge, what was there beyond the edges of the active retinochoroiditis, which could be clinically recognized. There was also an element of vasculitis which was very much prevalent in both the eyes. This is how the left eye was, where you had a hot disc, you had an element of vasculitis, and again you had a patchy hyperfluorescence which was corresponding to the retinochoroiditis patch. Now on the OCT, what you can very classically see are these intraretinal precipitates, which one needs to recognize and keep in mind when you are dealing with a patient of syphilis. So when we investigated her further, her HIV-1 was reactive, her CD4 counts were low, and her VDRL was reactive. So we went ahead and did a TPHA also, and which came out rightly to be positive, which confirmed the diagnosis that we were dealing with a syphilitic uveitis. So she was started on a heart therapy for HIV, and she was put on all these medications by the treating physician. She was also put on an injection of benzathine penicillin, 2.4 million international units intramuscular weekly for 3 weeks. Prednisolone acetate eye drops were continued for the anterior uveitis she was having, and oral valcyclovir and steroids were stopped at this stage. Now, what is important for all of us to remember is that we have to rule out neurosyphilis in such patients. So a CSF analysis was done, and rightly so, a 2 ml of clear fluid was taken. Now, an important learning for all of us is that when you are doing a CSF analysis, TPHA is something which comes out negative when you are analyzing the CSF, and what is confirmatory is the VDRL. So VDRL was positive in the CSF analysis that was done. The patient was also put on a second-line antibiotic along with the ongoing management. So after 3 weeks of treatment, a CSF sampling was again done, which now came out to be negative for VDRL, and her CD4 count started now going up. So after 2 weeks of treatment, you see there was a drastic improvement and a resolution of all her lesions in the right eye. However, the vitreous haze was quite bad in the left eye. So follow-up at 6 weeks, she had regained a vision to 618 N6 in the right eye. However, in the left eye, we were unable to salvage her vision, which dropped down to finger countings at 1.5 meters. And this probably was because of the extensive sclerosing of the vessels, which had already set in the left eye. Follow-up at 6 months, she improved marginally to 612 parts and N6 in the right eye. However, the left eye could not be, it could not recover the vision. OCT, of course, there was a resolution of all the intraretinal precipitates that we had seen initially. And we published this case as syphilitic uveitis misdiagnosed as viral retinitis, a misleading history. And why I highlighted this in the case report, that the entire thing was missed out because the patient said that she was unmarried, and that's why ruled out a syphilis in the initial presentation. So this is something we need to keep in mind. So syphilis, it's a sexually transmitted infection caused by Treponema pallidum, and it may also be transmitted from mother to baby during pregnancy or at birth, resulting in congenital syphilis. It causes serious long-term problems such as arthritis, brain damage, and blindness. So my take-home pearls from this particular case is that the history of exposure is extremely important, and we might be required to invest a little more extra time to get this history out. TPHA again is important for diagnosis and confirms our diagnosis of syphilis. We must check the immune status of our patient when we are suspecting a syphilitic infection. Neurosyphilis has to be ruled out in such patients, and VDRL is something which is important to help us monitor neurosyphilis management. Thank you so much.
Just like to highlight one point is the syphilis when occurs in the eye. Other opportunistic infections, CD4 count is relatively higher side. Other opportunistic infection you don't see. And if you see the subretinal precipitates, this kind of which is shown, is very diagnostic of syphilitic infection in the eye.